You're listening to This Week in Cardiology from theheart.org on Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for January 17th, 2020. This week, another note on XL, amyloid cardiomyopathy, drug prices, palliative care in cardiology, and gender bias at medical meetings. This week, I am keeping it brief on XL, a controversial trial of left main PCI versus CABG. The most recent news is the Society of Thoracic Surgeons, STS, drafted a letter saying that since any final conclusions from XL will not only affect the actions of doctors and surgeons and regulatory agencies and third-party payers, but more importantly, these results will seriously impact the health and well-being of our patients and their families for years to come. The Society believes that, quote, the final interpretation regarding the outcomes of the XL study should wait until an independent analysis of all aspects of the study have been performed. STS believes that such analysis will provide our best opportunity to get it right for the benefit of our patients now and in the future. So all three major cardiothoracic surgery societies, the EACTS, the American Society, the AATS, and STS have called for a reanalysis of XL. On one of my first podcasts on this trial, I called for the New England Journal to retract the paper at least temporarily to allow for independent review. Based on what is published in the New England right now and in the guidelines, a patient with left main stenosis diagnosed tomorrow could be told that the 5-year outcomes from PCI and CABG are similar. Two major groups of doctors disagree on that recommendation. Credible information have suggested the XL authors did not publish an unfavorable pre-specified endpoint, and another trial, the Noble trial, came to a different conclusion that coronary bypass surgery was the superior strategy. For all these reasons, and to restore public trust in medical science, New England should retract the paper, reanalyze it. Other cardiology groups should issue a pause on the current guideline recommendations until this independent review is concluded. Perhaps the independent review will uphold the current guidelines, but I think it's also equally possible that the current guidelines will need to be changed. Next topic is amyloid cardiomyopathy. Last year, the FDA approved a drug called tafamidis for the treatment of transthyretin-mediated amyloid cardiomyopathy, ATTR cardiomyopathy. This week, an editorial in JAMA Cardiology lamented the extraordinarily high list price of $225,000 per year, which now earns this drug the label the world's most expensive medicine for heart disease. First, let's briefly review amyloid heart disease. This is a form of infiltrative cardiomyopathy caused by deposition of amyloid fibrils into the myocardium, which cause restrictive physiology, heart failure, and arrhythmias. Amyloid heart disease is a terrible condition. Patients have lots of symptoms, and they usually die from the condition. The amyloid deposits could be of monoclonal light chains called AL, or they could be of transthyretin types called ATTR. Transthyretin amyloid cardiomyopathy can be inherited trait, and this is caused by pathogenic mutations in the transthyretin gene, TTR, or this condition can be acquired through the aggregation of wild-type transthyretin proteins, which is abbreviated ATTR-WT. Now, the wild-type form is seen in older patients who are typically male. The ATTR from the mutation is much more heterogeneous. The prevalence of this condition is a matter of debate, as it is often under-recognized and difficult to know. But now, since there is a $250,000 drug available, I suspect that the prevalence will increase. A very nice paper in Circulation from 2016, first author Gilmore outlines the non-biopsy diagnosis of ATTR cardiomyopathy. Briefly, this involves findings of uptake on bone scintigraphy scan and not finding a monoclonal protein. The drug tafamidis is a stabilizer. It prevents the breakup of the transthyretin protein, and breaking up of that protein is the first step in amyloid fibril deposition. The drug tafamidis earned approval from the results of a placebo-controlled RCT published in New England Journal in September of 2018. This was a study of about 440 patients followed for slightly less than 3 years. The drug reduced death rates a lot, 30% versus 43%, and it also reduced hospitalizations due to cardiac causes. Both of these effect sizes were large. The NNT for death, for instance, was 7.5, and for CV hospitalizations was 4. Now, interestingly, the Kaplan-Meier curves in that study did not differ until about 18 months. In other words, there was no effect of the drug, and then at 18 months, you see there's significant improvement in the drug arm. Now, the drug also improved functional measures as well, such as the 6-minute walk test and the Kansas City questionnaire. Now, third topic today is really going back to the drug price issue. Patrice Wendling has a nice recap of the JAMA Cardiology editorial that concerned the price. One of the main points of the authors was that tafamidis has FDA orphan drug designation, which is supposed to help people with diseases that are very rare, say less than 200,000 persons. But now, with these non-biopsy diagnostic methods, the prevalence of this disease is likely much higher, and the authors argue awarding of an orphan drug designation by the FDA and its associated market exclusivity provisions should be revisited. And the authors also argue that while innovators should be rewarded for innovation, they should also commit to responsible pricing of novel therapies. I want to emphasize responsible pricing. Now, I am no expert on the minutiae of FDA regulation and orphan status, but let's talk about the author's call to pharma companies to price the drug responsibly. While I am always for everyone acting responsibly, it's important to understand that drug and device companies have only one interest, and that is profit. And this is not nefarious, it's normal. For-profit corporations don't have human feelings or a moral compass. Their goal is to make money for shareholders, not to be nice. If a drug or device company makes a product that helps people, both society and the company win. Drug and device innovation has made this a great era to live in. I saw a patient recently with a malignant cancer that was deadly a few years ago, but now it's in total remission. That comes from innovation. For better or for worse, and economists argue about it, this is our system. A drug that costs $250,000 is obviously not ideal, but remember, if you decide to put your hand on the scales and regulate prices, you have to consider the potential reduction in innovation. Do we then get life-saving drugs with this more regulation? I don't know. Also, importantly, who gets to determine what is a reasonable price for a drug or device? Finally, remember that too high a price may limit the drug's use. Consider that the factor Xa antidotes, which are approved, but no hospital in my city carries it in a formulary because it's too expensive. Next topic is palliative care in cardiology. Now, reperfusion therapy of myocardial infarction with PCI has been one of cardiology's, no, check that, medicine's greatest success stories. It is amazing. Yet remember, friends, all humans die, and many of us suffer at end of life. Now let me tell you about a really nice study in JACC. Dr. Islam Elgandi and colleagues from Harvard, the group led by Dr. Deepak Bhatt, introduced their study on palliative care by telling us that in-hospital mortality for acute MI has not changed in recent years. That's surprising but it's because acute MI is so common and it doesn't always happen to a 50-year-old executive with few medical problems. Acute MI happens in older patients who are living with diminished organ reserve and multiple comorbid conditions. The authors culled data from the National Inpatient Sample from 2002 to 2016 using AMI as their diagnostic search. Their purpose was to describe the changes over time and factors associated with use of palliative care. And kudos to the news team at the Heart.org Medscape Cardiology and Patrice Wedling for selecting this important paper for a news story. The main findings of the paper are: 1, the incidence of palliative care penetration is low, only 1.3%, but it was slightly increased during the study period. Palliative care penetration increased mainly among those patients who died during the hospitalization. Third, among patients with high-risk features, there was also an increase in palliative care penetration, but it was mostly observed in patients with cardiogenic shock. And palliative care was more likely to be utilized in large urban teaching hospitals and in hospitals in the western part of the U.S. In the discussion, the authors tell us that the low use of palliative care has also been reported in the National Inpatient Sample for heart failure admissions. Then, of course, there was this very important paper by Heider-Warwick's group in JAMA Open in May, showing that patients with heart disease have significant symptom burden, but cardiologists provided comparatively fewer referrals to palliative care. During my last Heart Rhythm Society talk, I discussed the use of palliative care in cardiology, and one important fact that I learned preparing for that talk was that cardiology patients report similar degrees of distressing symptoms as cancer patients. So I think the next big gain in the care of people with acute MI and heart failure is not going to be a new drug or device. It will be to increase the amount of symptom relief these patients receive. And I've said this before. Stacy, my wife, who's a palliative care doctor, teaches that palliative care can be defined as PALS for people with serious illness. Palliative care is not the same as hospice. Palliative care should be concurrent with cardiology care. So congratulations to all involved in doing and reporting on this meaningful work. Last topic today is gender bias in speakers at medical conferences. A University of Texas research team reported a study describing trends in the demographics of speakers by sex who were invited to speak at the International Stroke Conference over a 5-year period. A quick background fact: 45%, nearly half, of neurology residents and fellows are female. So about 1,100 people were invited to speak over the 5-year period. Only 28% were women. This rate did not change. It was constant over the 5-year study period. Among 164 speakers who were invited more than once, only 21% were women. These numbers mirror faculty in neurology departments where men outnumber women at all ranks, and the disparity increases with advancing rank. The authors call this the leaky pipeline. In Sue Hughes' news article, 2 authors on the paper describe the extra demands on women physicians, particularly those in academia. For instance, the lead author, Lauren Fournier, noted that she will be unable to attend this year's meeting because she will be 8 months pregnant. Now, neurology leadership, like cardiology leadership, is working to improve this. First, they're publishing papers like this. This paper was in Stroke. Second, they're also including women on the organizing board of the conference. I report on this paper and this discussion because it is good news. As you all know, this podcast often talks about bad news, but this is good news. First piece of good news is noticing the problem of disparity. Noticing it is the first step. So a quick story about noticing stuff. This year, ESC recruited a group of doctors to be Twitter ambassadors to report on the ESC meeting. I was part of the EP group. There were about 5 of us, and it was fun. However, one of my writing colleagues noted that the EP group was the only group without a woman. But here's the thing. As a man, I just didn't even notice. So noticing stuff is important. I also find this good news that the next generation of leaders are moving to correct the disparity problem. My cardiology group is almost half female, and that is pretty cool. Finally, I want to end on a word of hope. Hope. I hope that adding more female speakers to meetings will improve the quality of the lectures. This is anecdotal only, but I have seen far too many male speakers drone on, reading text-heavy slides, and then committing the most major of speaking blunders, and that is going over one's allotted time. So that's it for this week in cardiology. As always, I am grateful that you listened. Thank you. And remember, if you like this podcast, please tell a friend, give us a rating, write us a review. These things really matter and help other people find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.